Welcome, everyone. My name is Phil Longman, and I'm the Policy Director at the Upmcs Institute and a Senior Editor at the Washington Monthly. And I'll also be your moderator today as we discuss and debate a topic that could not be more timely. So not so long ago, the prevailing wisdom about the American healthcare system was that it was the best in the world, but that it cost too much and left too many people uninsured. And so accordingly, our healthcare debates were largely focused on healthcare finance. Should we have Medicare for all, or maybe a public option, or maybe some people said healthcare savings accounts for all. But today, as we stagger through the fifth month of a pandemic and recession, and as we confront issues of racial justice with new focus and seriousness, a new view is taking hold, or at least should be. We are learning that the American healthcare delivery system is deeply broken and inequitable, even for those who have insurance. We're learning, for example, that decades of corporate consolidations have stripped out much of the surge capacity in hospital beds and even basic medical supplies that we need to deal with the pandemic. And we are learning that much of the nation's public health infrastructure no longer functions, including the capacity to keep timely and accurate vital statistics, let alone perform effective contact tracing or deal with larger socioeconomic determinants of health. And we are learning, as I wrote with my colleague Paul Glastris in an op-ed appearing in the Washington Post yesterday, that our hospital system is still largely segregated along racial and class lines, and that this segregation is amplifying the already horrible health disparities found throughout American society. So with us today are four people whose life work makes them uniquely qualified to help us understand the meaning of this moment and what its real and fundamental implications are for healthcare reform. First up is Shannon Brownlee. Shannon and I go back a long ways. We met while serving on the staff of US News and World Report in the late 1990s. And I think it's fair to say that we both became radicalized on healthcare issues there, including by the role played by the magazine's annual rankings of hospitals. Shannon subsequently went on to write a very important and influential book called Overtreated: Why Too Much Medicine is Making Us Sicker and Poorer. Today, she serves as a senior vice president at the Lown Institute, where she's played a key role in developing an alternative method for ranking hospitals that includes an important social justice metric. She'll be telling us more about that and also about her role in the Right Care Alliance, which is a grassroots coalition of clinicians and patients and members of the community organizing to put patients before politics. So Shannon, could you please sort of help us out today by maybe first of all talking about what it was that got you so committed to healthcare reform as an issue, and then also what is your take, your assessment of the moment we're at as these different forces of pandemic, recession, and social justice come together? What are the implications for healthcare reform?
So thanks so much, Phil. It's really a pleasure to be here, and especially with this cast of speakers, it's an honor. You know, it's funny, I've thought about this a lot, often over the years, and I think it was actually a single graph that really started me down the path of really questioning a lot of my own assumptions about how healthcare works. And it was a graph of, it was actually two graphs that were sort of superimposed. One was of healthcare spending, and the other one was life expectancy at birth in the United States. And as everybody who's in the audience probably is aware, healthcare spending has been going up and up and up and up at an extraordinary rate for the last 40 years. And life expectancy wasn't going up at the same rate, and not even close. And I started asking just a really basic question: why? Why is this happening? And it turns out, and that really was the sort of beginning of my radicalization. And the more I started to understand how the system actually works, the more I thought we need to do things differently. But the reason for that graph is, as most of the people in the audience know, is that we put a great deal of our money, if we look at the total amount that we spend on health, and people think that health spending is all about health care in this country, and it is. But in fact, health is built by a number of things. It's built by public health, as we're seeing the lack of public health infrastructure in this country having an effect in the COVID crisis. But it's also built by the community conditions that people find themselves with. It's the housing they live with. It's the food they have access to. It's whether or not their neighborhoods are safe. It's whether or not they have access to good education. All of these things, in fact, account more for your health as an individual than your genes or your access to health care. But what we've done in this country is we have invested the majority of our health spending, our total health spending, in the medical bucket. And what other countries, especially developed countries, the high-income countries and many middle-income countries are doing, is they're spending more on the community condition side and on the public health side proportionally. So the result is that we have some of the worst statistics in the high-income world, and even worse statistics than many middle-income countries. We have, really terrible infant mortality statistics. Our life expectancy at birth is somewhere around that of Costa Rica and Cuba, which is a friend of ours used to say, those are countries that ought to be beating us in baseball and soccer, not in life expectancy. So we've invested an enormous amount on the medical side. And where is that money going? It turns out the money is important because the money is power. Hospitals account for about 30% of the $3.6 trillion we spent on healthcare in 2018. Physician services account for a little less than 30%, and increasingly physician practices are being bought by hospitals. So, and many hospitals are multi-billion-dollar operations. By any measure, hospitals are a significant industrial sector of the United States. And for many communities, whether it's where my brother lives on the coast of Oregon or big cities like Pittsburgh, the hospital is the biggest employer outside of government, and often that's the biggest employer even when you take government into account. And so this big business is getting bigger. 2018 and 2019 saw unprecedented degrees of consolidation among nonprofit hospitals in particular. We now have more than 600 hospital systems, most of which are nonprofit. The biggest is the for-profit system HCA, which runs 185 hospitals, and right behind it is Ascension, which is a Catholic-run nonprofit system which runs 151 hospitals around the country. And what this does, this consolidation, has given hospitals enormous power in price negotiation with insurers. So the expected result of consolidation was synergy and economies of scale, but instead what we've gotten is the clash of the titans. So the insurers and the hospitals are fighting over prices. The hospitals wield bigger and bigger political power. And so their effect on healthcare spending, the healthcare piece can't be overestimated, but their effect on health, in the sense that they are sucking up so many of these dollars, is really important to think about as well. And in many ways, hospitals aren't held accountable for their performance. Now, they do deal with a fair amount of regulation, but they're not really held accountable for a number of things. They're not held accountable for what they pay their executives, for example, whether or not they take care of disadvantaged people, how they spend their community benefit dollars, which are required by the IRS for nonprofits, how much low value care they deliver. This is a special interest of mine, this problem of overuse or unnecessary care. And so they are not being held accountable. And part of the reason is the way we've been looking at hospital performance. And I blame a really nice man for that. His name is Avery Comero. He was a colleague of ours at US News, and he started the US News Best Hospitals ranking. And now all the rankings, with very small a couple of exceptions, look at patient outcomes. They look at mortality, mostly at in-hospital and 30-day mortality, And they're aimed at consumers, as if consumers, those people who used to be called patients, can make change in the system by where they end up getting their care. And US News is very open about it. It says the whole point of the ranking is that finding the best hospital for you. So other aspects of healthcare performance are not public. Nobody's measuring value of care. Nobody's measuring the rate of overuse, unnecessary services. Nobody's measuring things like, how much are they paying their janitors and their kitchen staff and their medical technologists. So we at Lown think there are really two ways to sort of change that paradigm. One of them is to change what you measure and make that public. And the other way is to build a different kind of power, union power, grassroots power. And so we're trying to do both of those things, as Phil said. The first one is we released the Lown Hospitals Index, and we did this in partnership with the Washington Monthly. And we do measure things like rates of overuse. We look at pay equity. We look at inclusivity, who are the patients that the hospital is really taking in, and do they represent the demographics, the racial mix, the education, and the income of their surrounding population. And second, we've launched a grassroots organization called the Right Care Alliance, which is clinicians, patients, community activists, because we think that this is not about thinking up really great policies. This is not, changing what's happening in healthcare is not going to happen from inside the system very easily. We think it's about power and it's about money. And one of the most important things is the power piece, and the only way you can really push on that kind of power is with people, with lots and lots of people on the ground. So that's basically what we're trying to work on.
Well, thank you, Shannon. That sets us up nicely to talk with our next presenter, who is Lisa Frank. Lisa is the Executive Vice President of SEIU Healthcare Pennsylvania, which is the state's largest and fastest growing union of nurses and healthcare workers. SEIU unites more than 1 million caregivers committed to creating industry standards and governmental policies that allow all people to enjoy good health. And in that capacity, she's helped tens of thousands of people, home care workers and hospital workers, to unite and raise their voices. And Lisa, we're so excited to have you here and to hear from a real practitioner, somebody on the ground fighting the good fight. So can you tell us a little bit about how the fight's going in Western Pennsylvania?
Sure. And as Phil says, I am from Western Pennsylvania. I'm from Pittsburgh. And so, we've seen some of these trends up close. Like Shannon, I'm very glad for this conversation. I think among my friends and colleagues, I don't know, people get a little tired of me saying, yes, we need to talk about insurance, we need to talk about payers, we need to talk about healthcare finance, but if we're going to talk about healthcare reform, we actually have to talk about the healthcare and the healthcare reform. And I'm also glad to have an opportunity to talk just a little bit about caregivers, which in my experience with people who report on healthcare and with people who make policy around healthcare is not always at front of mind when people talk about big healthcare systems. So the story that Shannon began to introduce, and that I know we'll be talking about together for a little while now, the story of consolidation and what that has meant for prices, what that has meant for which services are readily available, which services are not readily available, and all of that, has as one of its chapters the story of what happens to caregiving in the age of monopoly. So the first thing that I really want to say is that healthcare is an industry, as Shannon pointed out, and that caregiving is a job. That was not always so. If you're old enough or have grandparents who are old enough, you went to the charity hospital and you probably saw a nun, or you saw a volunteer, or you saw Medicare and Medicaid changed that, and that was a good thing because a lot more people got access to care. People did a lot less dying at home with no medical interventions. At the same time, that changed jobs that women and domestic servant kind of people did as an extension of their daily unpaid chores into something they began to do as a real job. And so it's important to understand, again, something that Shannon said, that in my state, Pennsylvania, UPMC is not just the largest employer in the Pittsburgh area, it's the largest employer in the state. And there are 17 states in which healthcare is the largest employer. So that's about 1 in 3 states now where healthcare, hospital systems in particular, are the biggest industries. You can guess where they are. Minnesota, you know, where we've got the Mayo Clinic, and Oregon, where there's Providence, and I'm happy to share the list if you'd like it. So hospitals and health systems are kind of the general motors of our times, and I think we have to start to think of them like the general motors of our times. We have to think about the fact that they produce cars, but we also have to think about the role that they occupy in the economy. And from that point of view, I just want to wrap down what consolidation and monopoly power has meant from the point of view of jobs. How does consolidation in this industry affect caregiving and caregivers? So the flip side of the coin of monopoly power is monopsony power. And if you had lots of economics classes, you know what that is. That means when there's one buyer for a service. So if you're in a market where all healthcare is being delivered within one system, that's the buyer of caregiving. And the same power that healthcare systems have when commanding price from an insurer for a service is exactly the same power that you have in commanding wages or uncommanding wages in some cases. And that doesn't just extend to healthcare. I've talked to so many people who are trying to bargain contracts in hotels or trying to bargain contracts in other parts of the service sector, where what they hear from employers there is, well, you know, if the hospital is paying this, why would we pay more than that? You know, that when you have the largest industry consolidated, that monopsony effect extends across the whole market. So that's one thing to think about, the sort of downward pressure on wages. There's lots of documentation of this. A corollary of that kind of power, if you are a young woman and you just spent $8,000 to get trained to be a CNA or a PCT or something like that, you're carrying a little debt, you're getting your job in the hospital, it's the only game in town. The pressure to keep that job is pretty high, because where are you going to go? Where are you going to go if you get fired? If you're a doctor in a town like that, you've likely, almost inevitably, you have a non-compete clause in your contract that says if something happens to you, you quit, you can't go to the hospital across the street or down the street. You got to move to the other side of the state, or you have to leave the county to practice. What's important about that is that it creates a kind of culture of, I'm going to watch what I say. I am a little bit fearful. And I think everybody on this call and on this panel has talked to caregivers, maybe Kavita's going to talk about this a little bit, has talked to caregivers who see things that they know ought not to be happening, who want to speak out about things and really just don't dare because the consequences are catastrophic. There's nowhere else to go to practice your craft. Maybe if you're making cars, that's okay. But I think in healthcare, you really don't want your RN to be afraid to speak up about conditions that they feel are unsafe. You really don't want your doctor to say, hey, should we be doing elective surgeries well into a pandemic? You don't, a culture of fear is not a good culture in healthcare, but it is, as I said, a sort of corollary of a kind of monopsony around employment. There's also what I would call pack up your toys and go home power, which we've seen when people, say in a community, want to say something about the building code because we're going to make a giant hospital building here, or they want to say something about maybe having a community benefits agreement. Well, if you're going to invest in healthcare, could we expect to see, I don't know, some nod towards a community benefits agreement or a community health needs assessment? Could we say, well, gee, we're going to invest tax dollars in this. Could we have a standard wage or a living wage here? When you have that kind of power, you could just say, well, if you impose those conditions, we just won't build it. Or worse, we'll just close it. And that has certainly happened in communities all across Pennsylvania. That's a tremendous amount of economic power to have, to be able to just say, we're going to close it. And in a place like Western Pennsylvania, which saw the closing of Steel and saw people commit suicide over the closing of Steel, which has seen what happens in Braddock when your health provider closes a hospital there and 600 jobs go down the tubes. That's tremendous economic power that people have, and allows them to have an outsized influence, I would say, in all kinds of policy, not just healthcare policy. And then there's just plain and simple direct power over some of the most critical social determinants of health, wages and benefits. I'll just tell you the story of one woman. Her name is Jane, and I promise I'm wrapping up. Jane is a service worker at a hospital. She got breast cancer. Now remember, her employer sets her wages, gives her insurance, and sets the price of the care in the first place. So Jane, through her treatment, begins to accumulate medical debt. Her doctor says, you really ought to be in a clinical trial. And she says, I can't afford to be in that clinical trial. I can't afford any more medical debt. The doctor can't believe it. What are you talking about? Of course, this is Charity Hospital. They go to the Charity Hospital office to try to get that all arranged. They can't get it arranged because she makes a little bit too much money to come under statute, the policy that the same institution is writing. They send her to Medicaid. She makes a little too much money there. Her life, of course, depends on the care that she's receiving, but in this case, it's really the HR department, not the oncology department. And the point that I'm trying to make is that the hospital itself is the social determinant of health in this case. And then the last thing I'll just mention is the outsized influence of hospital systems now in labor law, particularly under the Trump NLRB, where we've just seen ruling after ruling after ruling brought by health systems in these cases that make it exceedingly difficult for workers to shift the balance of power in the way that Shannon was talking about. So these are all stories about power, and they're often stories about the abuse and corruption and injustice about power, and that's power over people, power over patients, power over workers. But there is also the power to do something. And so the last thing that I'll just say, to pick up on what Shannon said, is we spend trillions of dollars in this country on healthcare, and if we could figure out how to marry that to the passion and dedication that caregivers bring to their jobs every day, we truly could create the beautiful communities that people want to live in. And I hope we'll find a way to have that conversation.
Well, thank you so much, Lisa. That's very inspiring. It's a lot to think about and discuss. Up next is Kavita Patel. I'm so glad to see you here, Kavita. She and I go way back. I'm really pleased to be writing Posse again on healthcare reform. In addition to being a practicing primary care doctor, Kavita's credentials include having served as a key aide to Valerie Jarrett in the Obama White House, in which capacity she played a key role in bringing us the Accountable Care Act. Since then, she's been affiliated with the Brookings Institution, where she served as a managing director of clinical transformation at the Center for Health Policy, and where she continues today as a non-resident fellow. You may also recognize her from her frequent appearances on NBC and MSNBC, where she's become a go-to expert for their coverage of the COVID crisis. So, Kavita, you wear many hats, you have many experiences, but I'm very eager, and we all are, to sort of hear your perspective on taking the measure of the moment here and putting it in the context of how you came to be a healthcare reformer and what current events seem to suggest are the promise of healthcare reform at the moment.
Sure. Thank you, Phil. And I just want to, I guess it's in true fashion, like a doctor, to be late to everything. I really wasn't trying to do that, so I apologize to the crowd. That was no means of disrespect. So I'm happy to be here. I want to thank Open Markets Institute and congratulate you on a great, you and Paul Glasters on an excellent op-ed in the Washington Post that I think highlights kind of the burning need for studies like yours, lists, quantitative, qualitative research into this very topic. And I put this broadly, I'll I'll just kind of open with like, there are times where I think I'm pretty seasoned and a pretty solid veteran of healthcare. And then I find myself kind of going, wow, it's really more screwed up than I ever thought it was. And I've been doing that a lot lately with COVID, but I just give you an anecdote, and I don't know exactly who's on the call. So this is truly just my own personal opinions, not to reflect any employer or to represent any of my patients or colleagues' interests. But one of the first memories I have when I resumed clinical practice in Washington, D.C., now about 10 years ago, was walking into a hospital that was acquired by Johns Hopkins. It was a community-based hospital. And in the first thing you saw when you walked in was, U.S. News and World Report ranks Johns Hopkins Medicine #1. And I'm getting the words exactly maybe wrong, but it essentially the ranking of the hospital. And I, as a, health researcher, policy expert, doctor, kind of found myself thinking, oh, that's really interesting, and didn't really think more of it. And then come to find out that ranking was probably one of the most valuable assets that we had, and became a very focal point of conversation when, for example, we were no longer #1. And I say all that just to illustrate when I went in a little deeper and tried to understand, why did our ranking change or what went into the rankings, it kind of opened for me a Pandora's box around what we perceive as value and who is the kind of arbiter or who is the author of what that value is. And so that I open with that anecdote because it really was for me a moment. That's actually when I had the pleasure of meeting Phil and Shannon and Paul and others more closely, and couldn't echo enough the need 10 years ago, but ever more so today, for having a very transparent way for our society to understand value. And I kind of use that very, very generically and broadly. So it'd be exciting to go into more detail. I think because of this background I've had in policy and the moment we're in today, I think that one of the conversations, hopefully, that we can have either today or in continuing conversations is building on the monopoly, the monopsony, and just to kind of, Lisa is absolutely correct. A number of the conversations I have today with physicians, more specifically, because the team is very large now, but physicians who I end up spending a lot of time with, both hospital-based and those like me who are community-based, we're all very scared to be as articulate. It's funny, in this era of social media and Twitter, et cetera, you would think it's the opposite, that physicians are much more comfortable vocalizing their concerns or distress. And that is indeed true. You do see physicians taking to social media after Black Lives Matter. You saw, we were all a participant in like a kind of a 10-minute time period where we basically stood still. And I think that you'll see that is a more public presence. But when it comes to self-reflection, inflection, or criticism, even if it's constructive criticism to say there's a lack of transparency about the financing of our organization and we're being asked to do more, but I'm not sure it's helping our patients. For example, you are basically told that you are violating contractual obligations or that you are not a team player. And I think that again, just building off of the trends in healthcare, I grow increasingly concerned that trend is worsening, not improving. I do think that when the Affordable Care Act passed in 2010, we had approximately 200, I'm going to get this number wrong also, so don't send me a nasty email with how I got the number wrong, but we had approximately 200 and some odd health systems that had at least a $10 billion kind of market value. That number has been chopped in at least half. And I predict in 10 more years, if trends continue, regardless of the political nature of the administrations, if what we do today and the role that private health insurance, employer-based insurance, and paying for procedures and kind of paying for procedures continues, then in 10 years, we'll basically have like 10 health systems worth somewhere between $20 and $50 billion each, much like you see in the insurance industry. Incredible consolidation and basically a handful of players that dictate kind of the terms. And I'll close because I could talk, all of us could probably give like the masterclass in all of these topics, but I'll close with just giving you like one bizarre true world example of where this is playing out. You actually have large publicly traded insurance companies. You can fill in the blanks of who they are, publicly traded on the NASDAQ and stock market, who are trying to prepay for cancer treatments at hospitals and oncology clinics because they have so much money and they have so much profits on the books. Because ironically with COVID, guess what? People are dying and getting diagnosed with COVID, but they're not getting their elective surgeries. They're not getting, a Kaiser study that came out in the Journal of the American Medical Association 2 months ago stated that their hospitalization rate for myocardial infarctions were decreased by 50%. And sure, there's a lot of unnecessary care in that equation, but there is a good chunk of people who really did need care and did not, out of their own fear or because the health systems were not able to take them in and weren't even available, did not get care. Who benefits from that? The American people aren't. We have 52 million and climbing uninsured, and people who are literally going to be homeless because they can't get stimulus funding or Congress can't get their act together. Meanwhile, you have for-profit insurance companies that are trying to prepay and spend out money. So this cannot continue. And I bring it back to what Open Markets Institute has done, because I think that as we're all trying to deal with these inequities and disparities, what you all have done serves as a foundation to try to address some of those. Is it going to address all of it? No. But I think we need to start somewhere, and I'm really happy that this group came together. So I'll stop there and see if that generates some controversy.
Well, you're good at that, Kavita. Thank you so much. And I'm looking forward to picking up some of those themes. But before we do, our last speaker is Uday Thakur. Uday is a research associate at the Open Markets Institute, where he coordinates work on a number of public interest coalitions, including the Freedom from Noncompete campaign, which is very germane, and Athena, which is a broad coalition of local and national organizations representing working people, small business, and people of color, immigrants, neighbors, and the like. He's also has also co-authored with me a piece appearing in the current issue of the Washington Monthly that profiles the University of Pittsburgh Medical Center and has the title Epidemic of Greed. And I'm hoping, Uday, that you can at least begin by telling us a little bit about what we discovered about this wonderful charitable academic medical institution that exists in Pittsburgh.
Absolutely. It's wonderful to be here with you all. And speaking of controversy, buckle up. So I want to begin my remarks with an acknowledgement. We've heard a great deal so far about the difficulties and travails of our healthcare system, but I want to begin by acknowledging the brave volunteers and voters who fought and won the fight to expand Medicaid in Missouri on Tuesday, those in Oklahoma who did the same just a month ago. And it's also worth noting that a new Congresswoman-elect, Ms. Cori Bush, also a nurse, and a Black Lives Matter organizer, has won her race in Missouri and will be joining us here in DC in some time. I do this on purpose because I think that more than any technical deficiency in our national conversation around healthcare, there is an aversion, dare I say a fear, to speak in candid terms about what is actually up for debate. It's a debate about corporate power versus democracy, the illusion of choice versus the reality of governance, and I'll be frank, racism versus those dedicated to an agenda explicitly of anti-racism. Now, there are movements amassing across this country, and as the crisis continues, it's incumbent, I believe, upon those of us removed from the worst ravages of that epidemic to use what time and energy we have to bring the stories of those less fortunate on the front lines of this crisis to bear on discussions like this. Too often, the technical nature of healthcare is used as a jockeying stick, a way for us to avoid difficult discussions. And I'm delighted to be joined by those who are interested in bringing those difficult discussions to bear on, the pressing work of those of us in DC today. So I want to keep my remarks brief and mention just a couple of examples. So it was very telling that there was, a 2016 article in the Journal of the American Medical Association, authored by none other than our recent president, President Obama. And in this article, a retrospective on the successes and failures of the Affordable Care Act, a number of items were mentioned, many of whom were quite clearly laudable. But I want to draw our attention and focus my remarks on two aspects in particular of this article. One is the explicit mention and, in fact, invocation of a sense of mission in the president's words, a sense of mission that had once been associated with the pursuit of medical excellence and care in this country, using examples such as, previous achievements of polio vaccines and so on and so forth. But the sense of mission that is also lacking in the pursuit of medical care today. I also want to draw attention to a curious absence, however, in this article. And that is the lack of mission that very much plays a major role in the governance of the institutional providers of our care, that is hospitals, and the obstruction that we quite clearly see in numerous examples. One that my co-author Phil Longman and I focused on in our article for the Washington Monthly was the example of the University of Pittsburgh Medical Center, an institution that is quite clearly an institution, not only of economic power in Western Pennsylvania, but of political power. And the history of this institution, intertwined as it always is with the history of medical care in the United States of America, makes both of these points quite clear, I think. I want to focus particularly, very briefly now, on UPMC's history in the context of American healthcare. So Paul Starr, the noted health policy expert and sociologist, has written previously about the curious tendency in American healthcare history and politics of the tendency towards rebound strategies, quote unquote. And in his words, a rebound has always occurred from a succession of defeats, first in the progressive era when state level campaigns for health insurance failed between 1915 and 1919, the New Deal, when the Roosevelt administration twice considered and rejected proposals to push for health insurance nationally, and the late 40s, when Harry Truman proposed national health insurance but never got so far as developing legislation. It's worth telling that in all of those cases, the opponents of reform labeled both FDR and President Truman as socialists or abetting the advance of socialism. And I think we should be honest about the fact that any approach at healthcare reform in this political climate, whether it is explicitly that of public option, Medicare for all, or as we plan to talk about today, the role of hospitals specifically, will likely be lampooned as socialism as well. So in the interest of elevating our intellectual and political conversation about healthcare to be worthy of the principles of democracy, I want to be quite brief now and say only that, so even as the promise of offering access to healthcare as a right of citizenship has remained out of reach for most of American history, the earlier New Deal state did help facilitate substantial investments in biomedical research through the aegis of the National Institutes of Health, while also passing legislation to invest in building new hospitals and academic medical centers throughout the country. The Hospital Survey and Construction Act of 1946, which is sometimes known as Hill-Burton. Funds from that bill were what went to build what we now know as the University of Pittsburgh Medical Center. It's important to say this because while the language of choice and exchange has come to dominate our understanding of healthcare today, this was not always the case. On the contrary, the politics of healthcare reform in this country have always operated in something between a rock and a hard place. We can't quite bring ourselves to speak about the essential public nature of healthcare provision, but when it comes to the governance of healthcare, we understand it quite well. With the passage of Medicare and Medicaid in the 1960s, President Lyndon's Great Society helped alter the balance of power between consumers and providers for a time. And with a guaranteed stream of payments for poor and elderly patients now in place, officials were hopeful that hospitals would soon no longer need to provide charity care at all. So in 1969, the IRS moved away from its earlier financial ability standard, quote unquote, and endorsed what we now know as the community benefit standard, which remains to us this day. The justification for the change at that time, in the words of one expert, are almost quaint from our viewpoint today. Hospitals seem to have, quote unquote, requested this change, not because they asserted that the free care requirement was too onerous or would put them out of business, but because they believed the new federal programs would eliminate the demand for charity care. We know the rest of the story for the most part. After an initial period of expansion, healthcare cost inflation has continued to rise over time, while major concessions made to the American Medical Association during the drafting of Medicare continue to be a drag on the system. So to tie that together and conclude in my own remarks, I want to just mention that in the case of UPMC, we see quite clearly an institution of public birth with manifest public privileges and a quite clearly public footprint that is nonetheless governed in an entirely private manner, accountable largely to a private board of governors, and unaccountable to the citizens and governments that surround it. It's not too bold to call them its supplicants, frankly. So I want to end by mentioning two clear examples from Phil and I's piece. One is, an interesting conflict that emerged just last year when the University of Pittsburgh Medical Center was once again brought into loggerheads with the state and local governments because of an ongoing feud that it's had with its longtime competitor, Highmark Blue Cross Blue Shield. Because an earlier agreement between Blue Cross Blue Shield and UPMC was due to expire and likely throw millions of individuals off of their coverage, the state AG was forced to step in and force UPMC back to the bargaining table to save quite literally millions of Americans from losing their health insurance and losing access to the only providers that they have in their vicinity. This was an interesting case for two reasons. One, the core of State Attorney General Josh Shapiro's case was directed both at the fact that UPMC operates as a charitable benefit hospital, and two, he drew on a very old line of legal reasoning that looked at the role of UPMC's status as a nonprofit corporation. We tend to think of corporations today as just sort of private entities that rule over us from afar, and that the best we can do is really regulate them as a matter of administrative law. It's important to know that UPMC, however, in being a nonprofit corporation, enjoys manifest private benefits. It is allowed to organize and enjoy limited liability. Its operators, while they are nominally owners, are quite literally not entitled to any of the same rights or burdens that ownership would otherwise usually imply, and that this offers an opportunity. In fact, Representative Dan Miller of Pennsylvania and Western Pennsylvania has introduced a bill at the state level meant to provide workers seats on the boards of nonprofit hospitals such as UPMC. And it's helpful to know that the IRS at present, as a matter of its community benefit standards, lists one criteria for qualification of community benefit, and that is the presence of a representative community board, something that UPMC has not had for quite some time. I want to end now, I apologize, by giving one additional anecdote on the question of non-competes. As Lisa and others have mentioned, non-competes are rampant throughout the healthcare industry, and in the case of UPMC in particular. But they also offer us a window into the soul of medical care today. In one particular example, The American Medical Association, as part of the Federal Trade Commission's recent workshop on labor markets and non-competes in particular, submitted a comment. This comment was to implore the FTC to not pursue a rulemaking that would ban non-compete agreements. And full disclosure, Open Markets Institute wrote in favor of such a ban. The AMA wrote explicitly that they believed that non-competes could be regulated effectively at the state level. Now, in a very telling follow-up comment from the American Academy of Emergency Medicine, who claimed at the time to speak on behalf of doctors who are employers, a conflict emerged, a very clear and what can only be called a class conflict between an emerging class of physician owners in and throughout the medical profession and those doctors and providers who operate as employees. Now, this is the reality of medical care today. And as I heard from one provider in state of Washington, we need to admit the fact that there is a caste system in medicine today, and we need to regulate to break that caste system. I'm going to leave my comments at that.
Well, thank you, Uday. I invite members of the listening audience to share their questions if they have some with us. Meanwhile, I'd like to pose one of my own. So I think amongst us here, there's some daylight between those of us who think the primary challenge here is to get the policy right, and those of us who think the primary challenge is to get the politics right. Obviously, you need to get the politics and the policy right, but it's a question of emphasis. So let me start with you, Lisa. What are your thoughts on, if you were philosopher king or queen, what would you do on a policy front, and how would you pull it off politically?
Okay, I'm going to be brief because I know everybody's going to have an answer to this question that's going to be interesting. I heard somebody say the other day, we need to stop talking about social determinants of health. They're only political determinants of health. And I think that's more or less right. And I see, the questions in the chat are like, well, yeah, but how do we get our arms around the nonprofits, and how do we, because what we're really talking about is power, right? In my experience with people, and I'm not saying, there wouldn't be some raucous conversation, there would, but in my experience with people, which is really thousands and thousands of people in this market, if you say to folks, hey, we got X amount of money and we got people who want to be healthy, what are your ideas about that? Some very basic ideas emerge pretty quickly, right? And these are all ideas that if you had the right politics, you could implement as policy, right? But we're just talking about who's setting the priorities here. That's really what we're talking about. So everybody arrives really quickly at, you know what, if you work in this place at a job that is, that needs doing, you should probably be able to feed your own family and not go into medical debt. That idea emerges really rapidly. Nobody thinks, I was saying to this group of people a little earlier, I sat down with a group of mostly Black women who do mostly service work in one of these hospitals. And we calculated that if you had started to work at today's wages in one of these hospitals as a cleaner or as a, at the end of the Civil War, and you had worked right up until today, you would still have a century to go before you would make as much as the CEO made last year. That tells us a lot about racial disparities of wealth. It would tell us a lot about racial disparities in health outcomes. How do we have in Pittsburgh the highest, second highest infant mortality rate when we live in the shadow of a $20 billion global health corporation? You get the idea. People can sort this out pretty rapidly, and they make very, very different investments than the small coterie of people who sit at the top of a very tall tower. So my short answer to the question is, we got to find the democratic levers on these institutions, have that conversation, and we'll make better decisions. And the not-for-profits, interesting because they don't have shareholders, are harder to get at than the for-profit corporations unless you have a very bold set of regulators. Attorneys general can intervene, as Uday mentioned, and so on and so forth. So that's my short answer. These institutions, the cure for this problem is more democracy.
Kavita, is the cure more democracy, or is it better policies, smarter policies?
Yeah, I mean, I'll offer just a little bit of a different take. I don't disagree. I've seen, and I have more comfort with understanding how economic policy drives so much of this. The growth of Medicare Advantage, in my opinion, is a great example of that. You now have entire, even large academic systems like some of the ones we just cited today, who are really trying to, quote, figure out how they fit into the MA market, because that's where the dominance of Medicare beneficiaries will be. And I've also been struck by how many health systems of all types and sizes are now trying to really meaningfully put a strategy in place where they have direct to employer contracting. So for me as a policy person, I feel like the financing needs to kind of lead. And David Pope asked a question that I'm going to type out a long answer to, but asking like, what would the ideal hospital look like? And I think this is part of it. For me, it would be a policy approach in the beginning that shifts financing, at least 20% of financing from fee-for-service to some sort of risk, and shifting the ownership structure, to Lisa's point, where the C-suite, which ends up having the highest incentives, both literally and figuratively, to kind of maintain a status quo, that becomes flipped, and that you have, kind of like a Denver Health model, where even the janitorial staff have like some say in the policies that drive the management of the organization. That's not 2020 Denver Health. It's how it was under some previous leadership. But we do have some places where this can be done, and policies allow for what Lisa's talking about in terms of democracy.
Right. Shannon, do you want to take a piece of that question? Need to unmute.
Great. I kind of want to unite what Kavita said with what Lisa said, because both resonate. So hospitals, we talk about greed, and this is sort of a journalistic trope, but the reality is that hospitals are responding to the economic and regulatory messages that they get. They're effectively acting within a system that is set up for them to do exactly what they're doing, which is to accumulate power, to consolidate, to demand higher and higher prices, and for C-suites to be able to take more and more of the revenue because unions are weaker and weaker. So they're basically, everybody's sort of acting within a system that was set up to do what it's doing right now. And I think there have to be both more democratic ways of governing how hospitals work, and they have to be much more local. We don't have anything like what we in the Right Care Alliance call health assemblies, which are effectively citizen experts who have some local authority over the behavior, the capital expenditures, the accountability of their local healthcare institutions. And we have school boards which do some of those things, but we don't have anything like that in healthcare. We've left it to the experts. We've left it to the people who have the greatest incentive for maintaining the status quo. At the same time, we have to have policy that starts to change the way hospitals are paid. And one of the things that has been talked about forever, but nobody's going to change it because there isn't much appetite for it within the C-suites for the most part, is fee-for-service. It's insane. It's crazy. Hospitals need to basically have budgets. They don't have budgets, and they need to live within those budgets because they will suck up all the available money in the sort of larger health spending of a particular area if they can. And that's the thing that that local groups have to understand and have to be able to have some kind of control over, because spending all of our money on hospitals is not the way to have a health system. It's a way to have a medical care system, an acute care system.
Let's close out with going around on the question of what is the order of battle today as we speak. I can make a one hand on the other hand analysis here very quickly, right? On the one hand, we have, as Uday alluded to, a potential division within the ranks of doctors themselves, between operator-owner doctors, doctorpreneurs, and salaried doctors. On the other hand, we have growing monopsony which causes everyone that's working in the healthcare sector to feel increasingly inhibited about speaking out against their employers. On the one hand, we have kind of a national teach-in going on right now about the inadequacies of our public healthcare system, about the racial inequities of our healthcare system, and yet I don't see any clamor from the public, from this great democracy of ours, to put healthcare reform front and center on our agenda. So maybe Kavita, since you've worked on Capitol Hill, you've worked in the White House, from your perch to start with, what's your sense of this moment in terms of, is there an opening here? Is there a moment to do something beyond the kind of patchwork reforms we've been doing for the last 30 years?
Yeah, I think there is. I think Uday kind of rightfully started his comments with the progress in Missouri most recently, but 5 out of 6 red state. I mean, would I have ever predicted you'd see this overwhelming tidal wave of support in predominantly quote red states? No. And I think that alone will put a little bit more tailwind to the confidence for a Democratic administration, because candidly, Democrats traditionally, I can say this as a Democrat, traditionally have kind of not necessarily wanted to be as bold. The Affordable Care Act was really just a way to try to increase access and not necessarily didn't even have a public option because of the politics of it. So I would like to say, yes, that we are going to have some of those tailwinds. My fear, though, Phil, candidly, is that we've gotten ourselves into such a bind with COVID. And I'm just going to offer some brutal reality. Hospitals, as much as we've been talking about them, if we had a column on the open markets kind of research that showed the losses on their books, and I think Shannon had previously spoken about articles that show that these are the same hospitals that might have taken payments from the government and not necessarily been equitable about who receives care for COVID. Bottom line is these are hospitals that have been hemorrhaging upwards of billions of dollars. And because hospitals are the largest employers in a community, you've got local mayors, governors, and eventually the White House that's going to be a little bit more sympathetic to them. And so I think the right way to have a bold approach that's not just incrementalism or tacking on a solution is going to be finding a way that creates a path forward. David Pope, whoever you are, thank you for asking this question about the future of healthcare, because in order to have that big conversation, Phil, you're going to have to answer that and show that hospitals aren't going to all get closed in the next 2 years in order to get their buy-in. And I say this as somebody who's had to cut deals in order to get buy-in. So that's what I think we're going to need.
Mm-hmm. Well, I couldn't agree more that we need a very positive vision of what the healthcare system looks like coming out on the other side, including the way it delivers healthcare, but also in the way it's governed. Lisa, do you
Phil,
want to
I'd like to very briefly address that piece, which is that, we created the Loud Hospitals Index, and we were delighted to have the Washington Monthly write about it, in part to change the way people see the hospital sector as one of the first steps. We think that that imagining a different system, you can't do it when you're stuck inside the current system. And so imagining what that different system might look like is partly a matter of framing the existing system. And so we created the index to give people a different set of metrics and a different view of how hospitals operate, what they actually do. And I can tell you that Johns Hopkins did incredibly well on avoiding overuse, which is really interesting because they're really focused on that. And we think that there are many terrific hospitals out there that are doing it all. They're doing a good job of caring for patients with low mortality, taking care of patients who are disadvantaged, who are, Black and brown patients, and they're avoiding overuse. And those hospitals need to be lifted up as a way of saying, not just to other hospitals, but to everybody, it is possible to have hospitals that do the things we think they're supposed to do. And that's what we should start aiming for. Now, my bigger vision of what the healthcare system should look like is that hospitals have a much smaller role, but that's down the road.
Mm-hmm. Great. Well, brings us to the end of our hour. I've very much enjoyed this conversation, and I'm so thankful to all of you that participated. And I hope we can go forth and solve this healthcare crisis. So thank you again, and take care.